everyone. This is Dr. Kishore Ratkalkar, your host for JFK Health Spot. I'm a board-certified physician, senior attending at JFK University Hospital, President Medical Staff right in the Medical Center and Old Bridge Medical Center, Medical Director for Long-Term Acute Care Hospital, Hackensack Meridian Health. My specialty is pulmonary and internal medicine. I want to thank Amy Thornton, our CHE and President of JFK University Medical Center, for the sponsorship for JFK Health Spot, and also to the entire JFK team. My special thanks to Ms. Thornton for supporting me in launching SACHI, a South Asian Community Health Initiative that is meant to serve the underserved and uninsured population in our communities. Stay tuned for more announcements for SACHI events in next few months. It will have health fairs and camps and care navigators, etc. Thank you, Amy. Thank you, JFK, for your support. Today's topic is on women's cardiac health. It is Women's Health Month, and the importance of women's cardiac health has gained significance. In last 100 years, it was only men's cardiac health. And now we realize over the last 2 decades or more, the importance of women's cardiac health. With me today to discuss women's cardiac health is Dr. Mariam Wassef. She is a board-certified cardiologist, highly trained. Her specialty is electrophysiology. She is fellowship trained in that field, and that deals with arrhythmias, that is irregular heartbeat, etc., pacemakers, and sudden cardiac death. And it is my honor and privilege to welcome Dr. Wassef. Welcome, Dr. Wassef.
Thank you so much. Thanks for having me today.
And let's start on the first question that I'm going to ask you is, what is coronary disease to my viewers?
So coronary artery disease, it involves problems where people have blockages in the blood vessels that feed blood to the heart muscle. So the heart is a muscle, just like any muscle that we have in our body.
Okay.
It needs blood supply, and that's how it gets its nutrients and its oxygen supply. So the blood flows through the coronary arteries that feed blood to the heart muscle.
Sure.
So we want to make sure that these arteries are nice, wide open, that blood flows freely with no problems.
Right.
Coronary artery disease is when we have problems with blockages, like plaque buildup inside these arteries
Sure.
that prevent blood flow freely from reaching the heart muscle.
I see. So if there is no nutrition like anything else, the trees die because there is no nutrition
Correct.
to the roots, and it's the same concept for the heart.
Yes, so the heart is a muscle. It
Right.
needs its blood supply. So if it's not getting enough food
Nutrition.
and oxygen, it's going to start to weaken and have problems.
Thank you. Thank you for that. What is the incidence of coronary artery disease in women?
It's actually a lot more prevalent what people think. So people think usually heart disease is associated with being a man, but heart disease in women is becoming more prevalent because we're more aware of it. People are getting to know that women usually don't have the typical symptoms for heart disease, so we started to present more earlier in the disease course to present to physicians and seek help for symptoms that may not be very typical to them, or they think maybe it's GI upset or like lung problems, and then they find out that they have heart disease.
Yeah.
And the trick for it is because usually women present with heart disease at a slightly older age than men because of hormonal changes. So usually people did not think of it very frequently, but it's very prevalent.
Yeah, I appreciate that, because the concept that they are protected with estrogens, etc., and then they are menopausal and postmenopausal, and then the symptoms start. And when they start, can you explain to our viewers the symptoms how they present, especially in women, because there is a subtle difference in the symptoms that men present with and women, and there is lack of understanding in general population that angina, chest pain, etc., it's male dominant symptoms, and there is a subtle difference. Can you elaborate and explain to our viewers what those symptoms are and why they are so different than male population?
Absolutely. So I want our viewers to, especially for women, to have their antennas up a lot more carefully than what men should be. And the reason is, with men, typically they have the standard symptoms like clutching their chest, saying chest pain or chest tightness, heaviness. For women, that might not necessarily be just the presenting symptom for having heart problems. So it's clumped as called being atypical symptoms, and that could be ranging from shortness of breath, just feeling tired even, just overwhelming fatigue with minimal exertion. Sometimes, especially for women, they have chest pain that's even at rest, which is very different from what men would have. Usually men would have chest pain and chest tightness if they're exerting themselves, like if they're walking for a long distance, going up and down the stairs, that would provoke symptoms. For women, sometimes with minimal exertion, or even if they're sitting down, they would have chest pain. Also, aside from chest pain, people may complain of just feeling nausea, vomiting for unclear reasons, dizziness, lightheadedness, with or without exertion. So these are the things to watch out for.
So, just for our viewers to know, a man will have chest pain on exertion, but his pain is usually relieved at rest. But in women, that's not the case.
Not the case, yeah.
So they may be resting and they will have a chest pain. And while men usually, when they exert, they take a break or a rest, and the symptoms improve.
Correct. So for women, it's a little bit different. They may have chest pain even if they're not exerting themselves. Sometimes they don't even have chest pain. It could be jaw pain, left-sided neck pain. These are the things to watch out for.
Oh, thank you so much. So the next, we are going to take a short break very soon. After that, I want to discuss, we discuss the symptoms, but we'll go in a little more detail in that, and also symptoms of heart attack, so that our viewers will understand what to look for and what are the warning signs for it. Thank you.
Yeah.
Welcome back. I'm here with Dr. Wassef, a board-certified cardiologist, electrophysiologist. And Dr. Wassef, I have to ask you this. Why does coronary disease affect women differently than men? And we'll continue with that. What are the risk factors for CAD in women?
Okay, so the reason women are affected differently from men, and they have even different presentation of coronary disease than men, is a few different things. First, and most importantly, is hormonal effects of estrogen on females. It actually does kind of serve as a protective mechanism for delaying atherosclerotic plaque compared to men. But we also have to keep in mind that in postmenopause, we start to lose that protection layer. So that's why usually women present with coronary disease at a later age compared to men. That's one thing. The other thing is how women are built. So unfortunately, women have typically smaller diameter of the coronary arteries. So the coronary arteries are like blood vessels that are the shape of a tube. If the tube is smaller, that's going to affect blood flow easily. So even if you have smaller amount of plaque, it's going to be more significant to cause blockages. So that's one of the other reasons why women are more susceptible to having heart disease that
Sure.
occur at an worse presentation, unfortunately, compared to men, because we don't have that diameter or blood vessel diameter reserve that men have.
The heart muscle is also
Smaller.
It's thinner than.
It's thinner,
Yeah.
walls are thinner, the heart is smaller, and also the coronary arteries are smaller.
Correct.
And also the blood vessel, the walls of the blood vessels are thinner, so it's more susceptible to building plaque and cause problems later in age.
Okay, so can you tell our viewers about the microvascular angina symptoms, or not the symptoms they get because of microvascular disease?
Absolutely. So the coronary arteries, they're the biggest blood vessels that come out of the aorta, and then they start to branch into smaller arteries that feed the heart muscle in different locations. So microvascular disease, it means that you don't necessarily just have plaque buildup in the larger arteries, but you do have plaque buildup in the smaller arteries that are actually digging within the heart muscle to feed tissue, to feed blood to the tissue within the heart muscle,
Right.
or like the hidden area or the smaller areas. If you think about it conceptually, if you do have problems or plaque buildup in the bigger arteries on the outside of the heart, that's easier
Right.
and more amenable for fixing with like physical stents. But the smaller arteries that are hidden or digging within the heart muscle, within the wall, they're much harder to be amenable to do anything physically to open up these arteries.
Right.
So the only thing we're relying on is delaying the process of atherosclerotic plaque buildup.
Right.
And that's with risk factor mitigation and also
Right.
treatment over the years that slow down plaque buildup within the
Right,
arteries.
because as you said, you can't just stent your way out of this.
No.
Because they are the small vessels
No.
and you can't access them.
They're just not amenable. The
to
only
any
thing we can do
intervention.
about it is decrease the amount of plaque that builds up
Correct.
and the calcification that builds up
We're
over the
being
years.
proactive and treating it.
Absolutely.
We'll get to that. So what are the risk factors for women especially for coronary disease?
So risk factors for women is actually going to be very similar to men. So the main thing that affect coronary disease is lifestyle. Obesity, unfortunately, is one of the most common risk factor for having coronary disease. Diabetes, high blood pressure,
Right.
decrease metabolic syndrome. So metabolic
Right.
syndrome, it's a combination of decreased activity,
Sure,
diabetes, high blood pressure, that just makes the body more prone to develop and
Right.
worsen atherosclerotic plaque over the years.
Sure. And also to add to that is autoimmune inflammatory processes that you have can also predispose you to those.
Correct. And these, sometimes it feels like these are things that are out of our control,
Right.
but even the most important thing are things that we can change in our lifestyle. And one of the most important things is tobacco. Smoking cessation.
Absolutely.
Smoking increases significantly the rate of plaque burden and plaque development.
Absolutely.
And these are things that we can change.
It really accelerates the whole process.
Absolutely.
Smoking does.
Yeah.
And that is, the same risk factors as it is in men. When you smoke, you get the same plaque buildup
Yeah.
and accelerates the processes. So, the importance of risk mitigation is what we will talk as we progress in this program. So you have said about why it affects differently because of the hormonal changes of the age and the relatively later presentation, and you alluded to the changes from metabolic syndrome to prediabetes. What about emotional disorders and stress?
That's one of the things that women are more susceptible to, and it's actually one of the common risk factors for having heart disease, and more likely compared to men that women will notice that their symptoms for coronary disease is associated with stress. So stress not only is a provoking factor compared to men. When they exert themselves, they have chest pain and anginal symptoms. For women, it could be related, it's more likely to be related with stress compared to exertion, but also stress in general increases your whole body inflammatory response, and
Sure.
it worsens atherosclerotic plaque burden.
Yeah. So it's important to all our viewers to understand, to mitigate the risk factors that we just talked about, but more importantly to focus on physical exercise, reducing your stress levels in your daily life, and be very cognizant that it's important for your well-being not to smoke, get enough rest, do what is required, and that will take you a long way in preventing coronary disease. We are going to take a short break soon, and Dr. Wassef and I will come back after a short break. Welcome back to JFK Health Spot. I'm here with Dr. Wassef, cardiologist, and we have been discussing women's cardiac health. The next question to you, Dr. Wassef, what are the tests in diagnosing coronary disease in women?
So there are a few tests that are the cornerstone for diagnosing coronary disease. The most important thing is the EKG, starting with the basics. So what an EKG is, it's a test that measures electrical signals in the heart, done with stickers around the chest, and then it just collects electrical information in the heart. And if you do have blockages that are suggestive for coronary artery disease, it messes up the electrical system. So this is the oldest test that's been around to diagnose heart disease, is by looking at electrical signals and waves of the heart's electrical waves to see if there's any suggestion for having blockages or coronary artery disease. Even though it's, this is the cornerstone, it's not all, because unless if you're actually having an acute myocardial infarction, it doesn't always give us a good information if you do have blockages or not, because a lot of times there are non-specific changes on the EKG that are actually not suggestive for having coronary disease in a patient, and other way around. Sometimes people have abnormal EKGs and yet they have pretty bad coronary disease. So, but it's a good step one, especially in the diagnosis of acute myocardial infarction. The next test that I turn to is depending on the patient's risk factors.
Sure.
So, especially, and it's becoming actually more popular, is a test called calcium score. I use it a lot. I'm a big fan of calcium score.
I do it too.
And the reason is, it's able to detect a calcium buildup within the coronary arteries, which is the building block for developing atherosclerotic plaque. So usually for younger patients who have heavy family history, or they do have risk factors at an earlier age,
Sure.
I'm not just waiting for them to develop blockages. I'm actually looking with a calcium score to see if they have any calcium buildup, that I know that they're going to develop heavy blockages down the road. And if I do see that, and if that test is abnormal, then I can offer them all the medications that we know of that can decrease the progression for atherosclerotic plaque and decrease the risk for having coronary disease in the future.
Dr. Wassef, there is a calcium scoring, which is a very important test to do. It's not usually covered by insurance. It is a $99 test which patients should go and get it done. Secondly, when you do calcium scoring, can you stratify the scores like 0 to 100, 100 to 400, 400 and above?
So just like any other test that we do, not just in cardiology, there's always zones for areas that can tell us if the patient does have high burden or
Sure.
low burden. For a calcium score, it's heavily dependent on your the patient's group, especially based on age. So if you're younger, with a calcium score that's in the intermediate range and like maybe 300 to 500.
Right.
For a younger patient, that's considered abnormal. That's
Sure.
considered
Sure.
high. But for an older patient, a calcium score of 200, I would be okay with it.
Correct.
Because we're bound to develop calcification, not just in our heart, but everywhere, as
right.
we age. But that doesn't necessarily mean having blockages. So that test, it has to be definitely interpreted within context of what's relative
Sure.
to the patient. I'm always happy with a calcium score of 0.
I get it.
That's what I want to see.
We talked about the calcium score. What would be the next step if you are in that category? Say nowadays we are doing calcium score, but not everybody is getting a calcium score.
Correct, yeah.
So those patients who get a calcium score in the moderate range, as you said, what do you do next?
Walked into the second cornerstone for diagnosing coronary disease, which is the stress test. And again, it's not, the calcium score is never going to replace the stress test. Sometimes, a lot of times, the stress test is more appropriate than a calcium score in the correct patient population. And what a stress test is, it's a test either through putting the patient on a treadmill versus giving them an injection that simulates stress. And then we want to see what the coronary arteries do when the patient's heart is increased and when the heart is at stress, to see if these coronary arteries are able to dilate to accommodate increased blood flow.
Sure.
Because like we talked about, the heart is a muscle just like any other muscle. When we're exercising, when we're stressing our muscles, there's got to be increased blood flow to catch the person up with whatever that muscle is doing.
Sure.
So that's what we're looking for with a stress test. So in patients who have an abnormal or borderline calcium score, which is not appropriate for their age or their setting, then I'm probably going to order them a stress test.
Okay.
It's still a non-invasive test, so that's, as long as I'm not suspecting an acute myocardial infarction or something that's going to be extremely severe, that's usually my go-to option.
So that will be a radionuclear stress test or a Lexicon.
Correct. So these are the different types of stress tests. So there is a treadmill type paired with an EKG, which is the stickers on the chest, versus for patients who have like orthopedic issues, if they have knee problems or ankle problems, I don't want the test to be limited by
Sure.
their orthopedic
Sure.
issues. I want it to be limited by heart's capacity, heart stress. So for those patients, I may choose to do a chemical nuclear stress test, which is slightly more accurate than just an EKG test.
Thank you for watching this very important show which covered topics for women's health, especially related to cardiac disease. We are looking forward to see you again at our next show. Thank you.